Welcome back. There's a consensus here in this studio that regardless of what is done about rationing or other efficiency savings that might be made, the NHS will go on needing more money, a real increase year after year, even if the pressure can be reduced somewhat by some of those ways that we discussed in part one. Now the question, how to raise that money? There are taxes, of course, and we'll come on to that, but there are also charges. There are already charges for prescriptions, dental care, eye tests, and they contribute more than 900 million to the NHS budget. Only a small fraction, but significant money nonetheless. The BMA has raised the prospect, or perhaps the spectre, of charging patients for GP visits. And in its self-proclaimed far-reaching Think the Unthinkable review, the government says nothing is ruled in, nothing is ruled out. So what's the potential here for savings, if any? Roderick Nye, Social Market Foundation, do you think that charges could be extended and enjoy some public support as well?
I think they could enjoy a degree of public support. Our survey of 2,000 members of the general public showed that roughly 2/3 of people thought that other people went to their GP too often because the service was free, and about 70% of them said that if they were to be charged, say, £5 a visit, they wouldn't visit the GP any less often as a result. If you were able to either charge people per visit or make them pay an annual fee in order to be able to go to the GP as often as they wanted, you could raise in the region of £500 million to £1 billion a year, which would go some way to closing the gap between the amount we spend in total on healthcare in this country with the amount that other OECD countries spend.
Let me then ask a member of the audience, Dr. Bala, who runs a GP service. What do you reckon?
Well, unfortunately, it's the great demand on the primary health care providers, the GPs and the other health care professionals. We must differentiate, as we were talking about, what the patients want or what they actually need. And as far as the question of payment is concerned, it's only the minority who abuse the free system. It's to make them educate, make them aware that, look, this service is there to be used appropriately, and who is lumbered with the primary health professionals. And if, end of the day, they are made to pay, I'm sure that they will use the health services far more responsibly. We all GPs are aware that they've got so much unrealistic expectation out of all doctors, nurses, and other health professionals.
So you would get more responsible use of the resources if people had to pay, as well as raising £500 million or whatever it may be.
That will raise only because certain proportion will be paying, but that will make the other people aware that how to use the services more appropriately and more responsibly.
Another doctor, Jean Stanton.
I have great concerns about this. I'm a GP in inner city Luton. There's a very high level of deprivation in the town. And I think the way to do this is to educate them. And this is what GPs do every day of the week. We educate them as to what is reasonable, what's not reasonable.
But do you have lots of people coming in to you who shouldn't be coming to see you because their problem should not be, as it were, your problem?
Well, they may come in at the beginning, but they are educated, I hope, en route so that their expectation and demand changes. And we bear that in our practice as a great move.
And why are you concerned about charging? What effect do you think charging would have?
Well, I think we have to bear in mind that when somebody calls a GP or comes up to see me, I think it's quite a stress to ask themselves, do I need medical care? You know, it's difficult for people. They're not medically qualified, so they've got to find that out for themselves.
Dr. Bala was suggesting that people come in, he didn't use the word, but he might have used the word frivolously in medical terms.
I think it's down to us to educate people. And I, having done this now for the last 10 years in our practice as a determined effort, I actually think we have changed the way people use our service. But I must say, can I just say
yes, of course.
I have great fears about charges, because given that it's difficult for somebody to decide if they want medical care, then whether they have it, whether they think they've got the money or whether they perceive they've got the money to pay for it, is just going to stop them coming. And I think in some cases, it's going to prevent them seeking medical care, and there's going to be some disasters.
Because they really urgently might need it.
In the first place.
I mean, some diagnosis that
Absolutely.
wouldn't be made.
And it's not dependent on how much money you've got in your pocket, it's whether or not you perceive you've got the money to pay for it.
Dr. Chisholm, BMA floated this idea, which raised the political temperature, among other things. What made you float it?
Well, I believe, and the BMA believes, in a service that is free at the point of use and where access is based on need. It was raised as a concept because we are so aware of the underfunding of the service. But the trouble is, if you introduce charges, it moves you from access based on need to access based on ability to pay. And however you set levels of exemptions, there will be people caught in the poverty trap, people who are not exempt but who haven't got the money to pay, and people who actually need our services will be deterred from seeking them. It's only a minority of GPs who are supporting this. We know this from both national representative surveys and from conference votes, that the majority of GPs are still committed to a free service. But the trouble is, it's because GPs are so overworked that their workload is going up, that the demands made on them continue to increase, that a minority of GPs think of charges.
But would you contemplate any charges designed to, as it were, ratchet up people's awareness of the expense of the resource they're using? If people don't turn up, for instance, to surgeries when they've made appointments, if they don't turn up at the last moment at the hospital where precious space has been made available for them, would you have any sanctions that would involve charges in that form or not?
No, I would not. I would agree with Dr. Stanton that those issues should be dealt with by a process of education rather than of punitive fines.
Rick Nye, your ideas being given the thumbs down? Not entirely, but partly.
Well, if you look at that other great institution that everybody in Britain supports, which is the BBC, people, the vast majority of households pay £80 a year for the privilege of having a set, watching the BBC, perhaps watching this programme as well. For something like £2 a week, you would be having the same subscription service to get as many visits to the doctor as you felt you needed. And these charges wouldn't cover anything other than non-emergency access, and obviously A&E services would continue to be free, but you do need to find a way of, if you like, personalising the rationing dilemma among ordinary members of the public, which all the healthcare professionals in this audience knows exists.
Julian Legrand.
The problem with charges is the problem of exemptions. What happens is that when you introduce a system of charges, there's enormous pressure to start exempting people. First of all, you exempt the poor for very obvious reasons. Then you start exempting children. Then somebody says, well, what about the elderly? We can't have our senior citizens charged. Then somebody says, what about maternity? And before you know where you are, you've exempted 80, 90% of the population.
But there are charges already. Doesn't the same argument apply in dental care, for instance?
And indeed, we get exactly this consequence. Something like 85% of the population of the users of prescription charges, for example, don't pay them.
The government is thinking the unthinkable, or inviting people to think the unthinkable. For you, is this unthinkable as a doctor, Dr. Stote?
It's not so much unthinkable as unworkable. I think this idea of a subscription charge, I think it would have exactly the opposite effect. I think it would drive up demand. People would say, I'm paying £80 a year for this service, I want more of it. And I think, and the other problem is that if you charge people at the point of use, if you charge them a fee to come to their doctor, then firstly you're going to penalise people at the margins, and you always will, whichever system you use, people at the margins will suffer. And I think there's no doubt about that already with dental and eye charges. But just to make another point, I think it will drive people into the secondary sector. They'll say, I haven't got the money to go to my GP, I'll go to casualty. I'll dial 999, I'll call out an ambulance. It will give the wrong impression. It's the idea of a carrot and stick. If we use a stick to beat people, we'll have exactly the wrong effect. If we, on the other hand, take Dr. Stanton's point about educating people about the most appropriate use of services, that's a way forward. I don't believe anybody knowingly goes to their GP frivolously. It may turn out to be frivolous when they get there, but they don't knowingly go with that idea. They go because they've got a problem. What we must do as a country, not just as a government, but as a country, is to ensure people are given the means to know when it's appropriate to go to their doctor, when is the best use, what is the best service to use, so that we can get more efficiency.
Rick Nye, have one more go at that.
Well, I think you need to be able to construct a system where, with triage or whatever, at accident emergencies, already people turn away people on access to the accident emergency services. You're seen by a nurse.
What's triage?
You're seen by a nurse to see whether your condition requires the attention of a doctor or not.
Right.
The point is you need to be able to construct a system here where people understand that every time they present themselves to their doctor, they are costing money, and they are costing money to a public service which has implications for other people as well.
OK. Now, let's look then at what has been waiting to come out in this discussion, which is taxes. Whether they are direct or indirect taxes, we reach the point where there is a consensus, certainly on this panel here, that that money is going to have to be found. Dr. Stote is looking uncomfortable at this thought as a Labour MP. The question of hypothecation is a horrible term. It basically means earmarking taxes specifically for a particular purpose, in this case for the health service. Jean Traynor, does hypothecation, earmarked taxes, appeal to you as a way, perhaps, of getting public support for increasing taxation because they know exactly where it's going?
Well, I think that we're getting our NHS very cheap, actually, and I actually also believe that the fairest way of collecting money for the NHS is via taxation. If the government has cut down the option of getting it from income tax, there are other options that we can look at. Obviously, the government can find money from elsewhere. Our economy is growing, unemployment's going down, we're earning more money, so we ought to be directing that growth back into the NHS. But if we're going to look at hypothecation, in a way we already have a hypothecated tax in our national insurance. And I don't see any reason why we shouldn't be looking at that as another means of gaining money.
Earmarking national insurance contributions specifically to the health service and building them to the level which would be required to finance a growing health service?
I think so, yes.
What do you make of that, Professor Legrand?
Well, I think it's quite an interesting idea, especially since some of the other demands on national insurance are being eroded, such as pensions, for example. And there are other possible alternatives. The take of VAT, for example, is about the same as the amount of money that's spent on the health service. So you could earmark the whole of VAT receipts for the health service. Or you could use cigarette taxes or taxes on alcohol.
Sorry, what happens if there's a recession and VAT receipts don't rise at the rate needed to finance the ever-growing demands that you were talking about at the beginning of the programme?
Well, that, of course, is the big problem with hypothecation, is that the revenues from the tax don't necessarily go in line with the needs of the health service. If, as you say, you have a recession, it might mean that the demand on the health service increases as more and more people are unemployed and the rest of it. But at the same time, the resources going into the health service via a hypothecated tax go down.
So you would have to find some way of having a little money in the back pocket against that.
And once you do that, you've eroded the whole principle of hypothecation.
Rick Nye, hypothecation?
It's a very blunt instrument, and it doesn't give the users of the service any sort of feel that the extra money that they're paying is necessarily being translated into a service for them. I mean, for instance, you could have had a hypothecated health tax under the last government, and I'm sure that Labour people on this panel would have said that some of it was going on company car perks to NHS administrators. It doesn't really build up the kind of loyalty that you want to the health service in the way that its advocates say it does.
Thank you. Let's ask again, patients and public, there are lots of hands going up on any of what you've just heard, questions of hypothecated tax, whether it should be general taxation, whether charges could help or not. The man there, second in, third row back.
We've seen in the news this week the suggested changes to the patient's charter to make patients more responsible for certain aspects of their healthcare, including things like timekeeping and courtesy to staff, which is obviously a necessary input. We've heard lots of debate here about items of education. We still have in this country a very reactive rather than a proactive health care system. Will the government have the guts to make those people who follow adverse health behaviours, such as smoking, physical inactivity and poor diet, responsible and make higher charges to those individuals for the service which they demand most from?
Let me hear another view. I'm going to bring in people who haven't been in before. The man, third row back. Yep.
Yes, I believe that if you ask the general public if they would pay extra taxes for health, they would actually pay extra taxes for health. Now, this is the general consensus that I feel when I speak to the general public.
Governments always think, including Labour government, that although people say, oh yeah, we want to have more taxes on health, when it comes to bringing across in the ballot box, somehow or other they vote for the party that they think is not going to give them the more taxes. Sorry?
Perhaps when we actually vote, it has nothing to do with that. Perhaps it's a much bigger issue.
Maybe. Gentleman here.
I think the people will fork out extra money for the taxations, but I feel already the prescription charges going up and up and up, and we have reached to the saturated point of £5.65 per items. I am a rural country